One thing that you may or may not know of is that in 1966, a particular protocol called fat transfer was approved in this country, and I'm Australian, so it was approved in Australia at the same time. And most people, when they relate to fat transfer techniques, they think of cosmetics. They think of a filler, something that's used as a filler on the face. But if you have a look at before 1966, because usually most of the online PubMed don't go before that, but if you have a good look at some very old articles, and I was alerted to them by an American plastic surgeon who's been around for a long time, you will see that fat as an autologous transfer technique was used not just in cosmetic procedures. You'll see from 1895, you'll see that in the Medical Journal of Australia, 1914, free fat and fascia transplantation in the treatment of ankylosed joints and diseases of the bone. You'll see it plugged into ankylosed humeral ulnar joint. You'll see some very interesting papers around World War II where it was widely used to even plug bullet wounds and military wounds. And I first came across it when I was working in Africa with the military there, where I saw a French military surgeon take out some fat to plug someone's bullet wound, and I thought it was the most weirdest thing I've ever seen. I go, what the hell are you doing? And so it's something that has been used for a long time outside of just fat transfer. But what's the quality about fat? What is it about fat? That if you take another tissue and put it somewhere else, I mean, does it mean it's going to survive? It's going to necroticize? What is it? So it was well known that fat had some form, or at least the stromal side of fat had some form of healing or some form of supportive structure when you put it into a tissue that required such. So when we talk about adipose-derived stem cells, or I prefer to call it stromal cells, there's various aspects that a lot of the technology, a lot of companies are looking at, and a lot of the universities. Why the sudden surge in adipose-derived stromal cells or mesenchyme stem cells is the fact that it's a very rich source of it. It's an extremely rich source of it. And so this enables someone to get a very high number with a very simple particular procedures, which makes it a bit more practical and a bit more simple. And so there's a lot of work being done on non-expanded, just looking at the stromal cells themselves. There's work done on non-expanded, but a very specific cell type, where you take the stromal vascular fraction, you take it a few steps further and isolate that characterize a particular cell you're looking at. There's others that look at adhered cells. Other groups who've been looking at expanding the specific type of cell that you're interested in. And of course, there's a lot of work done in tissue engineering where you're taking the source autologously from that patient and pushing it to differentiate and turn into the cell type you want. And so that's where it seems to be. Now, most of our work has been mostly on non-expanded, on just using the stromal vascular fraction in itself. Sorry guys, I'm just trying to, there we go. So basically it involves doing a mini liposuction. What I mean by mini liposuction, many groups, including ours, but many other groups, show that the abdominal area or the inguinal area seems to have a higher or better quality concentration of these stromal cells. Anything close to the reproductive tract, that's what most of the research has supported. Using machines to suck out to the fat, or using some high pressure vacuum destroys the cells, that's well known. Using a small cannula to take out a small amount of fat is also positive. So these are various things that people have found out over the years. So anything that gives you a more finer lipoaspirate, and anything that doesn't destroy the cell through suction. And also this is also used for fat transfer protocols. They then look at, well, how can we, when we talk about digesting the fat, what are we really doing? What we're really trying to do is remove the lipid portion, is remove the adipocytes containing lipids. It's one fraction that we're trying to remove. The rest is we've got stromal cells. So there's various groups who use various enzymes such as collagenase, trypsin, which was originally used, hyaluronidase, lipase, various enzymes. We looked at at such simpler things such as lecithin liposome, something that may help emulsify the fat. Because simply separating it after is just a centrifugation step. Your lipids come up the top, and even just using gravity, and your cells go down the bottom. So there's plenty of literature on that. Then groups started looking, well, we're taking these cells out, so by just taking cells out, it doesn't necessarily mean that these cells, by putting them back into a source, into a damaged area or so forth, it doesn't necessarily mean that they're going to do anything. Why is it that you get 1 in 100,000 cells which will give you a colony forming unit when you clearly know, looking at the phenotypes, there's a lot more than that there? So we looked at looking at the physiological role of what these cells do, or what activates them. What activates them from an S0 to an S1 stage? What activates them from a dormant to an active stage? Well, we know there's at least 127 proteins and peptides known to stimulate or to induce these cells from a dormant to an active state, and it's also in bone marrow. We looked at various frequencies of light. There was some interesting research that was published looking at different frequencies of light, and particularly infrared, low-level infrared. And it's well shown in mostly, you'll find a lot of articles in the Russian and Korean literature where it's still used in internal medicine, putting fibre optics of an infrared light into patients with immunosuppression to increase, and it's still a well-known thing. Also, can we further cell-specific separate and isolate and so forth to further enhance what it is we're doing once we understand that it's the stromal cells that are causing these clinical effects? Some good research looking at, what attracts a stem cell or a stromal cells. What is it that attracts these cells or activates these cells to go to a damaged region? One thing that's been well shown, hypoxia in the tissue will attract them. SDF1, hepatocyte growth factor, is something that's well published. Platelets, which you've heard of all today, platelets contain a plethora of different goodies, as we call them, or growth factors or chemokines. So if I injure myself, platelets will go to the area, release what it has to release, which will attract and mobilise stem cells to go to the area to support the tissue and heal the tissue in that area. So, understanding that, we then went further and said, well, there's some work we've done in the EU looking at to trace CD29, CD90 cells derived from the patient's stromal vascular fraction to find out using simple traces that they use for inflammation for monocytes. In this case, we use 99 technetium. Indium 111 tends to be very good, and this is done with a nuclear medicine professor there who's an expert in that area. And you can see we've done an infusion of this patient's cells, and you can see there's uptake in the liver, lung. That's some background that you'll always get in the large intestine and bladder. But very interestingly, he had Dupuytren syndrome in the right hand. So he's got 12 nodules in his right hand. And 24 hours later, we hardly see any cells in his left hand where he doesn't have that condition, but he does have that in his right hand. So inflammation is obviously something that attracts these cells to that area. So that's just one example of looking at homing, and we're doing some more work with the University of Melbourne in animal models as well to further classify where do these cells go, and is it that these cells go to that area and support and heal that area? They're questions to ask. But we know that if I use the model of a wound, platelets go to the wound, plug the wound, keep it sterile, induce other factors in the surrounding tissue to heal. It works brilliantly in a 5-year-old, doesn't work as well in a 90-year-old. Bed sores are a testament to that. But, and so if we look at some work that was done by Kaplan, you'll clearly see, if I look at mesenchyme cells from bone marrow, that if I look at a newborn, we've got highly active and a high number of active cells, but as we age, it really drops. Now, this is a very important factor when we start looking at autologous therapies clinically. Fat, which we're working on now and looking through won't give you such a drop, but it will be a drop that also occurs. So you'll get less, if you look at colony-forming unit assays, you'll get less active cells coming out of a stromal vascular fraction. So this is very important. So we tried to say, well, if we can use something that's non-invasive, can we use either lights or growth factors or various platelets, can we use, when we take that out of an 80-year-old, will activating these cells or getting more S0 to S1 cells reduce this, because what it will do is it will reduce the clinical outcomes. You'll get far more consistency in clinical results. So that's something very important.